The changing paradigm of treatment in rheumatoid arthritis. Currently, we treat with traditional DMARDs, the methotrexate, but the evolving paradigm is early and aggressive treatment is most important. Second thing is combination treatment with different DMARDs and then immunosuppressive agents, and of course the third important area of change is the use of biological agents which are directed against the immune process itself. Now, after having made a diagnosis of rheumatoid arthritis by using the clinical criteria TAS 28 score, then we need to start the treatment. The first step would be to consider whether the patient has got risk factors for disability and erosions, whether this patient will go in for poor prognosis like a positive anti-CCP, positive rheumatoid factor, multiple swollen joints, elevated acute phase reactants, DR4 plus shared epitope in the genetic environment, erosions on the X-ray and presence of disability. If any of these features are present, this particular patient is a candidate for poor prognosis. If such factors are absent, that means they are not there, then we can give him a trial of COX-2 inhibitor, selective COX-2 inhibitor, which is COXIP plus HCQ, that is hydroxychloroquine, with or without low dose of oral glucocorticoids. So patients who do not have adverse features of worsening, patients who do not have risk factors for disability, they will be first treated with selective COX-2 inhibitors or hydroxychloroquine with and without oral corticosteroids. And people who respond to that regimen, we continue to treat them like that. People who do not respond to such treatment and they have persistent synovitis for over 3 weeks duration, then they will be considered for the next step of therapy. Here on this side, if patients who have these risk factors for disability and erosions listed here, if those factors are present, early aggressive treatment is the answer. What is that early aggressive treatment? Methotrexate or combination of DMARD therapy. Either you give one drug, disease modifying agent methotrexate, or use a combination of DMARDs, methotrexate with or without hydroxychloroquine, with or without sulfasalazine, with low dose glucocorticoids. These low dose glucocorticoids are for the takeoff. The patient, and to get symptomatic relief, we have to give them either low dose glucocorticoid or NSAID before the disease modifying agents take off. That takes around 6 weeks to 8 weeks. So during that period, these glucocorticoids, oral glucocorticoids will be given in low doses and then they will be tapered off. So patients who are put on methotrexate or combination of the DMARD treatment along with HCQ or without HCQ or sulfasalazine or a low dose glucocorticoid, with low dose glucocorticoid will be given, and people who respond for that, we continue the patients on that particular regimen. People who partially respond to that, then we need to add another drug to that methotrexate or combination DMARD. Now we add them leflunomide. Leflunomide is again an immunomodulator. This immunomodulator leflunomide is available as Arava, or if leflunomide is not given, we can think of the biological agent TNF blocker. But TNF blocker is expensive. Okay, people who responded all right, but they had toxicity for the above regimen of methotrexate or combination DMARD. In such a case, we switch the treatment from methotrexate or combination DMARD to leflunomide or TNF blocker. This is called switch therapy. Or the other alternative is the patient may be totally a non-responder. He did not only partial response, no toxicity, but totally they did not respond to the combination of methotrexate or other DMARD combination. Then you add leflunomide or TNF blocker. So the first level of treatment would be methotrexate or combination DMARD with HCQ or sulfasalazine along with low-dose corticosteroids. Patients who do not respond, they continue in the same treatment. Patients who are having toxicity with that, or they're partial responders or non-responders, all of them we will either switch or add leflunomide and TNF blocker. So with this treatment of leflunomide and TNF blocker, if people respond, we continue the treatment. If there is no non-responders or toxicity for these agents, consider other biologicals like abatacept, rituximab and immunosuppressive drug like cyclosporine. In nutshell, this is the algorithm for management. So the emphasis here is early use of aggressive therapy. Second thing is use of disease modifying agents, one or more disease modifying agents from the beginning, and addition of new disease modifying drugs or immunosuppressors or biologicals if there is no response within a matter of 12 weeks, and then continuing the treatment and monitoring for the toxicity. That is the algorithm for rheumatoid arthritis. Now look here, the synovial fibroblast, the macrophage, the beta cell, the dendritic cell, the T cell, the osteoclast, several cells are involved here. So we are now trying to find out treatments which will interfere with any one or more of these cells. For example, bone erosions due to osteoclast can be prevented by a drug called denosumab. Whereas T helper cell stimulation, cytotoxic cell activation and then coupling with dendritic cells can be blocked by abatacept. Whereas T cells stimulate the B cells to produce more of the immunoglobulin towards the Fc component of the IgG, and those B cells can be blocked by a drug called rituximab. Now we have various lymphokines and cytokines. Interleukin 6 blocked by tocilizumab, whereas our NSAIDs block the prostaglandin E and other prostaglandins related to inflammation. TNF alpha blocker are used to block the TNF. Interleukin 1 blocker, anakinra, is used to block the interleukin 1. So vascular endothelial growth factor, matrix metalloproteases, interleukin 8, interleukin 17, interleukin 6, prostaglandin E, interleukin 23, interleukin 15, tumor necrosis factor alpha, interleukin 1, all are the various chemomediators and chemokines. The synovial fibroblast, the macrophage, these contribute to these chemokines. What is their action? They produce inflammation of the synovium, they cause tissue damage, they cause acute phase response, they cause neovascular degeneration and pannus formation and synovial proliferation, pain and swelling, neutrophil infiltration and vasculitis. So by blocking these areas by different agents, either at the level of the osteoclast by denosumab or at the level of T cell dendritic cell interaction by abatacept, or blocking the B cells using rituximab or tocilizumab for interleukin 6, NSAIDs for the prostaglandin, TNF blockers for the TNF alpha and anakinra for interleukin 1, we can interfere with the mechanism of production of inflammation. Now, these are some of the various areas at which the blockers are available. Newer drugs are being tried to see that whether we can influence the prognosis of the disease or progress of the disease in a positive way and reduce the inflammation by blocking the action of one or more of these chains in this pathogenesis. Now you see the new treatment paradigm of rheumatoid arthritis. Earlier, simple analgesics. If the analgesics are not effective, intra-articular corticosteroids or higher doses of steroids for the extra-articular disease were being tried in good olden days. But today, patient education, counseling, making the patient understand his disability, and then the physiotherapy by qualified physiotherapists, occupational therapists to put them right back into their occupations, the presence of the orthopedic surgeon in the team to see that 25% of the patients who require surgery are immediately given early benefit of surgery. So patient education, physiotherapy, occupational therapy and surgical procedures are today's paradigm. Yesterday's paradigm of simple analgesics, intra-articular steroids and flares with extra-articular disease being treated with higher dose of steroids has gone. Now, mild disease at the onset, severe disease at the onset, moderate disease at the onset, there could be 3 grades. So, for the mild disease at the onset, it's okay, patient education, physiotherapy, little bit of analgesia may be okay. Whereas for those with moderate or severe disease, we have to start with non-steroidal anti-inflammatory drugs, NSAIDs, low-dose corticosteroids, and then give disease-modifying agents like leflunomide, methotrexate, hydroxychloroquine, sulfasalazine. These are the drugs. Olden days treatment like gold or gold alone in combination with other DMARDs is being sometimes tried, but gold salts and penicillamine have been on the back burner now with the advent of new DMARDs. Azathioprine, an immunomodulator, biologic response modifiers, the biologicals, D-penicillamine, an older drug, cyclosporine alone or in combination with other DMARDs is the second step. New and experimental agents and procedures are being tried for those people who do not respond to the conventional combinations of DMARDs plus leflunomide plus biologicals. Then of course we are left with experimental methods of treatment. So this is the new paradigm of treatment for rheumatoid arthritis. A word about the biological agents in rheumatoid arthritis. We have seen the biological agents are specific molecules tailored to tackle the immunopathogenesis of rheumatoid arthritis at different steps. We know that there are 2 important chemokines and cytokines, the TNF alpha and the interleukin 1. So the fundamental step would be to block the TNF alpha and alpha activity by TNF alpha antagonist, or interleukin 1 can be blocked by an antagonist. The TNF alpha antagonists are adalimumab. Adalimumab is Humira, it is available, etanercept, Enbrel and infliximab, Remicade. These 3 directly block the action of TNF alpha. Interleukin 1 antagonist is anakinra. Anakinra is available as Kineret. This directly blocks the action of interleukin 1. Or we can suppress the T cell activation by using a drug called abatacept, Orenca. Or we can block the B cell monoclonal antibody against the immunoglobulin G by using the drug called rituximab or Rituxan. These are the newer forms of treatment. Remember that these forms of treatment, though are available, some of them in India, they are highly expensive, and each sitting of treatment, each dose of treatment might be costing anywhere around 25,000 to 30,000. These monoclonal antibodies against the TNF alpha or the interleukin or the suppression of the T cells or the B cell monoclonal antibody rituximab. But the results are somewhat dramatic in some patients who are not responding to other forms of treatment, but sometimes toxicity is a problem. So another important aspect here is we should not combine an interleukin 1 antagonist and a TNF alpha antagonist for fear of infections, for fear of sepsis and other related problems, because if we interfere with both the TNF alpha and interleukin 1, the patient might go in for severe septicemia. So these are some of the biological agents that are now available for selected group of patients. This slide summarizes some of the characteristics of the biologicals that are used in rheumatoid arthritis. Etanercept, the target is TNF alpha. Infliximab targets TNF alpha. Adalimumab targets TNF alpha. Anakinra, interleukin 1. Abatacept, T cell activation. Rituximab, B cell. That's what we have seen in the previous slide. The half-life of these drugs: etanercept 3 to 5 days, 8 to 10 days, infliximab, adalimumab 10 to 20 days, anakinra 4 to 6 hours, very fast acting, abatacept 13 to 16 days, and rituximab 19 days. So this is from the human origin. This is chimeric, again human, rituximab again from chimeric molecule. Dosing once bi-weekly or weekly, once every 4 to 8 weeks, once every 1 to 2 weeks. This is daily because the action is very short-lived, whereas once monthly and twice every 6 to 12 months. The route: subcutaneous here, intravenous, subcutaneous, subcutaneous, intravenous, intravenous. Once again, remind you that these are reserved for those patients who did not respond to conventional DMARDs plus the combination of the DMARDs plus of course the lefulanamide added. In such a case, that you are left with only the next step, that is the biologicals. The biologicals, you can either target the TNF or the interleukin 1 or the T cell or the B cell by using one of these drugs. Usually a combination of biological agents is not preferred. What are the relative contraindications of biologicals? Active hepatitis B infection, multiple sclerosis, optic neuritis, active serious infections in the body, chronic or recurrent infections, current neoplasia, history of tuberculosis or evidence of COX elsewhere in the body, congestive heart failure of class 3 or class 4. These are the relative contraindications for the use of biologic agents. Some of the safety considerations of biologicals: serious infections, opportunistic infections like tuberculosis, malignancies and development of lymphomas, demyelination, hematological abnormalities, suppression of the hemopoietic chain, administration reactions, congestive heart failure, hepatic toxicity, autoantibodies and drug-induced lupus, and then vaccination. These are some of the safety considerations of the biologicals, and during vaccinations we cannot give the biologicals because they interfere with the development of immunity by the different vaccines, and likewise in case of serious infections and in case of malignancies also we need to be very careful, particularly when there is congestive heart failure or hepatic toxicity. We need to be, when there is hematological abnormalities, then the safety considerations of biologicals will take an upper hand, and one need to be cautious with these agents, though their response is quite dramatic. So these are some of the modalities of treatment that we have seen. Once again reiterating that the treatment of rheumatoid arthritis today's paradigm is early treatment, as early as possible after the diagnosis. And this treatment, not only NSAID, you have to give DMARD. DMARD is disease modifying anti-rheumatoid drugs. Disease modified anti-rheumatoid drugs, the cornerstone of treatment in rheumatoid arthritis is methotrexate, either alone or in combination with other DMARDs like HCQ or sulfasalazine. If not responsive, add a bit of little glucocorticoids for the takeoff and then taper the glucocorticoids. If the patient is not responding or has toxicity for those partial response, then we add lefulanamide or TNF blocker. So reserving the TNF blockers, the interleukin 1 blockers or the T cell activator blockers or the B cell interfering blockers for those who do not respond. The biological agents are not directly used or routinely used. They are kept as reserve drugs, and those who can really afford and those who really deserve those drugs, only the biologicals have to be used, keeping in mind the safety precautions, keeping in mind the toxicities due to those agents. So friends, with this information that I have provided you, I think we have come to the end of this presentation on rheumatoid arthritis, and I thank you all for your attendance as well as attention, and thank you very much once again. I remind you once again that this presentation and host of other presentations of ours are available on the website www.drsharma.in. I request you to take full advantage of this website. Thank you all.